welcome back to week 2. I'm Amy Van Pelt, and I'm a postdoctoral fellow in the Department of Medical Social Sciences. And I'm excited to be here to talk about determinants of implementation with Dr. Allison Carroll.
Thank you so much. And I am Allison Carroll. I'm a clinical health psychologist by training, and I joined the Bridges team about 3 years ago. Been around in various roles in this course for a while, so really excited to be here with you all today. So next slide, please. I will start by just giving us a bit of an overview of what are we talking about when we're talking about determinants. Also, apologies that there are maybe some noises from my background here today. And then Amy's going to go a little bit more in depth on the Consolidated Framework for Implementation Research, or the CFIR, one of your readings today. A lot of the determinants frameworks are very similar, so we're going deep on one to give you an idea of what we're talking about when we're thinking about the context. I will also introduce the Health Equity Implementation Framework as another example of a determinants framework. And then we'll wrap up with some brief introductions to additional frameworks, considerations, and some limitations of using these frameworks. And then we'll go into our discussion group. So next slide, please. So what are we talking about when we're thinking about implementation determinants? We are thinking about what are the factors that determine what works, why things work, and where they're going to work. So why does an intervention work or fail? And also why do the implementation strategies work or fail? The determinants can be either positive or negative, which is where we get the idea of facilitators and barriers that you've likely heard of before. And so facilitators are all of the things about the context that make things work for us, whereas barriers are things that might impede implementation or an intervention working and might lead to failure. Determinants may act as barriers, or they can be mediators, and they're often used to guide formative evaluation. You will often see this as the third aim of an effectiveness trial in a grant, for example, to start to explore the context so that once we establish effectiveness, we can start to think towards implementation. And I'll give you just one other thing that I found really helpful when I started with implementation is to think about implementation determinants. We're all much more familiar with the idea of social determinants of health. And so we see one item is on a spectrum. So social economic status, for example, or SES, we can see on a scale when you have low socioeconomic status, that can be a barrier to health. It can be a barrier to accessing healthcare. Whereas when you're high on the scale of SES, that could be a facilitator. There might be more financial resources. There might be there are fewer barriers. That is a facilitator to accessing health, to having insurance coverage, to being able to get in to see a specialist. So in case that's at all helpful for any of you, I found that really helpful in thinking about a determinant as being on the scale from barrier to facilitator. Next slide, please. So I also wanted to harken back to some of the baseline introductory themes that we explored in our first session. And so when we break it down out of the jargon, implementation determinants, or when we think about the context, are those conditions that make it easier or harder for others to do, quote unquote, the thing. And next slide, please. So as we apply this in our implementation research logic model that you may remember, we're starting over here on the left. And as you can see, the determinants, or understanding the context, really lay the base for the implementation that's going to come next and what we'll continue to explore in our future sessions of selecting and specifying the strategies, then assessing the mechanisms, and then evaluating the outcomes at the end. Next slide, please. And then one last slide to reorient you here. We're keeping in mind that all models are wrong, but some are useful. And the only incorrect model is one that is misapplied. So here, when we're thinking about determinants frameworks, it's because we want to understand and or explain what influences implementation outcomes. Next slide, please. Just in summary here, context is central. It is the base for everything that we're going to be talking about in terms of implementation. And also, there are at least 17 determinants frameworks based on a 2019 review. So we are giving you highlights today of a couple that are just really commonly used. And with that, I will turn it over to Amy.
Great, thanks so much for queuing us up. And something to add, given the mixed audience of folks here, for those who may be more familiar with efficacy or effectiveness trials, I feel like in those studies, we often try to design or control for differences between sites, But in implementation science, it's the opposite, where context is not seen as a problem and it really influences the implementation process. So really summarizing and emphasizing that context is central. As Allison mentioned, we are going to do a deep dive on one of the many determinants frameworks, and one of the most popular for understanding context is the Consolidated Framework for Implementation Research, and you all may have heard of this referred to as CFIR. So CFIR is a framework for the systematic evaluation of factors that affect implementation across ecological levels. And we do know that you all read the updated CFIR for class today, but we thought it would be helpful to explain the original framework, since most of the literature published to date includes this original framework. So essentially, CFIR is a meta-theoretical model, meaning that it was developed by synthesizing prior theories, models, and frameworks. And that is helpful because one of its strengths is that it's quite comprehensive. It includes 5 domains and many constructs that we will discuss in detail over the next few slides. But one of the limitations with this framework, and really the state of the field of implementation science in general, is that we don't have a way to understand the relationships or the interactions between those constructs and between those domains. But nonetheless, CFIR has been widely used in over 375 studies to assess implementation context and progress, as well as really help explain findings. For example, if we were to identify what the barriers and facilitators were to implementation with regard to those different domains. And this last point here, before we dive into the details of the framework, we wanted to just highlight that given that CFIR is so comprehensive, we want to emphasize that it's important to select the constructs that are most relevant to your study and not try to use everything in this framework. Here's the figure that you all saw last session. To reiterate, CFIR consists of 5 domains, including outer setting, inner setting, intervention characteristics, characteristics of individuals, and the implementation process. And we'll walk through each of those domains in detail now. Starting with the outer setting, this domain refers to external factors that affect implementation, like government policies. And we thought it'd be helpful to try to concretize these domains by sharing a running example throughout each of these domains. So briefly, from a study that I recently completed, we engaged in pre-implementation contextual inquiry to plan for the future implementation of this computerized neurocognitive battery called the CNB for children and adolescents affected by HIV in Botswana. And we interviewed 20 individuals in the public medical sector in Botswana from 3 stakeholder groups. And just to note, for those who are interested, both of our interview guide and our analysis plan was guided by CFIR. So any folks who want to use CFIR in the future, I'm happy to talk through what that looked like. For the sake of time, I'm going to just highlight a couple of the key highlights from this work. So with regard to the outer setting, mental health and cognitive issues were described interchangeably by most of the participants, and we thought that was perhaps due to a lack of a unifying definition of cognitive impairment in this setting. Opinions on healthcare workers' awareness of cognitive issues varied, but really the majority of participants commented that community members do not understand the root cause of mental health and cognitive issues, and instead, these underlying deficits were commonly attributed to behavioral issues like a playful child or labeled with terms describing poor intelligence like stupid. There was an interesting discussion around academic performance as a proxy for cognitive function, where cognitive impairment is most commonly identified by poor school performance, which then overwhelmingly stakeholders noted that mental health resources are extremely limited in this setting, and existing screening methods rely on subjective evaluation. And as a result of all of that, children typically require a referral to receive psychological evaluation, but there's really limited capacity, which has resulted in long wait times to see a psychologist for evaluation. And really overall, there was a strong need for this screening tool. With regard to the inner setting, this refers to internal factors that affect implementation, such as clinic structure. For our study, participants explained that the Ministry of Health and Wellness typically has the authority to approve the integration of a new tool in the medical sector, and this is quite common across settings. Participants also described that there's a typical process for implementing new interventions, and there seems to be a high degree of reliance on written guidelines specifically and standard operating procedures for incorporating new tools. Resources is quite common when we're thinking about inner setting. So the availability of physical resources like a computer or a quiet space for the administration of this tool, that varied depending on the setting. But with regard to human resources, participants described really a shortage of staff of all specialties, but especially mental health clinicians. And in some settings, staff turnover was quite common. Intervention characteristics refers to components of the thing, components of the CNB in this case, components of the intervention. For our study, the discussion really focused on the strengths and the weaknesses of the computerized nature of the tool. With regard to strengths, participants described that the tests were appealing to all stakeholders, including children, because it was game-like, and providers because there was ease of administration. Some individuals commented that the automated scoring of the tool was an improvement over manual calculations of the current methods that are currently used. And then further, the lack of specialized mental health training that's required to administer the tool was also really emphasized as a strength. But I do want to highlight that although the majority of participants considered the computerized administration a strength, some individuals were concerned about children's computer literacy and the availability of computers in some settings. And also the duration of the CNB was really articulated as a potential challenge because the current time constraints may not be conducive to an assessment that takes between an hour to an hour and a half to administer. So as I'm describing these themes, you can see that there are both barriers and facilitators that were articulated within all of these domains. Characteristics of individuals refers to factors that are related to the people involved with implementation, such as self-efficacy. And you can see a couple of the additional characteristics listed here. In my study, overall, really, participants expressed there was high acceptability of this tool, and they thought that it would provide an important necessary resource. They did stress the importance of training clinicians on the administration of the tool as well as interpretation of the data. And although most individuals recognized the importance of cognitive screening, they did anticipate some healthcare workers exhibiting pushback and reluctance to implement this tool because they're already overworked and have too many tasks and responsibilities. But this pushback could also come from patients because they already have a long time to wait to see a provider. So they may oppose waiting a longer time to take a time-consuming assessment. And finally, implementation process. This refers to how to implement the thing. And I feel like folks often conceptualize this domain as implementation strategies, which you all will learn about in detail in the next session. But to wrap us up for the CNB study, stakeholders, they recommended various strategies for the implementation process. For example, individuals proposed administering the tool in both the medical sector and the educational sector. Most respondents describe targeting screening for children with the greatest need, such as those who may be assessed through poor school performance or are in high burden HIV clinics. And participants, they advise really leveraging current roles by having clinicians who already interact directly with the patients administer this assessment. So that may be a nurse or psychologist, depending on the setting. And again, emphasizing integration into existing guidelines. And also participants, they suggested designating a specific computer or room, as well as a specific day for CNB assessments. And you can see a couple of these additional themes here, but just to close us out, participants, they really stressed the importance of receiving buy-in from all stakeholder groups, and they had interesting ideas on how that could be facilitated through tailored education. For example, for leadership and clinicians, participants encouraged really communicating the value of this tool and helping children. But for the community, participants thought it would be helpful to increase awareness of cognitive impairment in general to encourage people to seek out support for cognitive issues. So hopefully some of those examples were helpful to concretize what we're talking about when we're thinking through the domains of CFIR. But if you all have any questions, please let us know in the small group discussions. For now, though, we want to pivot to highlight that there is an updated version of this model, which we're excited about, and I'm interested to see what the uptake and the adoption will be of this new model. You all, I believe, read this paper for the session today, so I'm not going to go through CFIR 2.0 in detail, but I do want to highlight some of the motivations for these changes. Starting with this first point, this updated model, it increases the applicability of this tool, of this framework, by replacing the term intervention to innovation, really to be more comprehensive in referring to the thing to be implemented. It also increases specificity of the actors. Patients were replaced with recipients to refer to individuals intended to benefit from this innovation. And they also added the concept of deliverers to specify the individuals involved in delivering the innovation. Modifications, they also involved adding additional constructs to include important themes that may have been missing from that original version, such as local attitudes, meaning sociocultural values and beliefs. And this final version, or this updated version, who knows if it'll be final in the future, it includes 5 domains, 48 constructs, and 19 subconstructs. And I do think these changes were helpful in improving this framework, but we want to highlight that equity is still very limited in CFR. So given the importance of health equity and implementation science, there are still limitations with this model, with this framework. Here's an abbreviated version of that table that was in the appendix that compares the original CFR to the updated CFR. And I find that a strength of 2.0 is that it provides guidance on really how to operationalize the domains, specifically with instructions to define the subject of the domain, replace the broad construct language with project-specific language, and the ability to add constructs that capture any themes that may not have been listed in CFR 2.0. So you can see here how the different domain names compare between the two versions, and outer setting and inner setting remain the same. The intervention characteristics, that domain was modified to be more comprehensive to the innovation, and characteristics of individuals, again, was changed to overall have individuals, but then a subdomain of characteristics. And finally, the implementation process is similar. And most of these changes, I feel like, were in the constructs, which I couldn't include that full table here. So if there are folks who are interested, I encourage you all to look at that table in the appendix. And as we wrap up the discussion of CFR, I do want to just highlight that there are additional tools and resources that may be helpful if you decide to use CFR in your projects. Specifically, there's a website that gives detailed definitions for each of the domains and each of the constructs, as well as helpful tools for data collection and matching determinants to implementation strategies, for example. So feel free to check these out as well.
And just wanted to point out that Sarah just posted in the chat a link directly to that CFR guide, I believe, the interview guide. It's definitely would not want to use it unedited, but is a really helpful place to get started. Really helps, and I think Amy mentioned this, of just clicking around helps you to become much more familiar with those different areas. So in part to address the fact that there is not a lot of equity integrated into many of the determinants frameworks, we're going to present the health equity implementation framework. So next slide, please. This was published in 2019 and was bringing together IPARIS as an implementation framework with the healthcare disparities framework. So the way that, in addition to having the internal and external or outer setting domains, it tries to explain factors underlying differences in healthcare for vulnerable populations. So once again, rather than that more expanded look at the CFR of using innovation and recipients, we are back pretty strictly in the healthcare setting with this framework. So those factors that they're looking at, as you can see on the figure, are the patients, such as their beliefs about treatment, providers, such as the time demands that providers are under. It includes the clinical encounter, so thinking about the patient-provider interaction and communications that occur between the provider, but also the system and the patient. And then the healthcare system, such as the hospital's commitment to reducing disparities, thinking about its culture related to quality improvement, all of those factors in the healthcare delivery. So next slide, please. So because it was only published in 2019, obviously we haven't had a whole lot of applications of this. So I just pulled this one out as an example. Hopefully Amy's walkthrough with the CFR gave you a good idea of how to apply a determinants framework even beyond the CFR, but just to share how this one was applied. This was for a study looking at examining the perspectives of potential implementation of the Dime Mas intervention, which is for Latino men who have sex with men. And the stakeholders that they interviewed were outreach workers, prep navigators, counselors that they were working with, the managers and staff, so a whole wide range. And what they did was they identified emergent themes from the qualitative data, and then they took those themes on the left and mapped them onto the health equity implementation framework. So just keeping an eye on what those various themes were. In the next slide, I pulled just a quick screenshot of the very top of this very large table, just to give you an idea of what this looked like, of trying to blend these together and get something out of this health equity implementation framework. So on the far left, you see the broad theme or domain that emerged from their qualitative research, thinking about cultural context, within which they identified points of stigma, affirmation and cultural competence, the language, and immigration status. And then you can see on the right-hand side, the 6 domains of the health equity implementation framework. And so where those pieces intersected, which I thought was a really interesting way to approach this. So again, a lot more to be done with this and kind of figure out, can we broaden this beyond the clinical realm, and what would that look like? And also, how can we better integrate equity into some of the other determinants frameworks that we already have? And with that, I will pass it back to Amy.
I believe it's still some additional frameworks.
Just kidding. So we are going to breeze through these because we just wanted to share so that you have them in the slides. So the theoretical domains framework, which is one that is largely focused on constructs from, or includes constructs from behavior change theory. So might be more familiar to some of you if that's kind of your area. The next one I'll just point out is the PRISM. And so you can see there, it's the extent to which patients are at the center of organizational processes. So again, compared to the CFIR, it was much more centering, CFIR 1, much more centering of patients and the recipients' experiences, which CFIR 2 has tried to address. And so those are there with the references for your interest, and happy to discuss those further in the group discussions as well.
Great, thanks so much for highlighting those additional frameworks that I think are really helpful. But just to wrap us up, I wanted to take a few minutes to discuss some additional considerations when we're thinking about determinants and context in general and implementation science. So we saw that we have a lot of frameworks, but despite these multiple determinant frameworks that are really helpful, we do have some limitations. This first point here, the existing frameworks, they're not relevant to all settings. So we know that some of our tools were developed with healthcare settings in mind, for example, but implementation research occurs beyond the healthcare setting. So some of these concepts may not be relevant. In addition, as we heard previously, a few of our frameworks include a health equity lens, which is critical for implementation science. But we really need more movement in this direction in the field to incorporate equity throughout all of our tools. And I alluded to this next point earlier when talking about CFIR, but we don't have a great way to understand mechanisms. We can use these tools to understand determinants of implementation, but they don't really tell us how these barriers influence implementation, for example. And I do believe some folks in the field are working on this now, so I'm excited to see what comes out of that. And finally, these tools are helpful to understand context of implementation, but we don't stop there. This is really just the first step in that implementation science subway map. And I'm slightly biased with bringing up this next consideration, given that I'm a global implementation scientist, but I do think it's important that everyone is thinking about the inequity in the application of implementation science between high-income countries and low and middle-income countries. So a lot of our tools, they were developed in high-income countries, which presents various limitations for application in LMICs. For example, some of our constructs are not relevant to resource-limited settings. We also heard that just with the example of CFIR being for healthcare settings, so it's more generalizable than that. And there are also important concepts in global health that are missing. And this last point here, there are other accessibility concerns, such as linguistic barriers, because most of our tools are primarily available in English. So to highlight this with a framework that we all are familiar with now, there was a systematic review of CFIR in LMICs, and it revealed that there were constructs that were not compatible in these settings. They also identified a need to propose a new domain called characteristics of the systems that's related to things like external funding priorities, which are really important considerations for this context. So I just wanted to highlight this example here because I think it's important for us to continue to assess the relevance and the appropriateness of our frameworks. Which I think this transitions us well into the last part of our talk. That was a paper that was assigned for this session today related to future directions for providing conceptual clarity related to context and implementation. And really just to briefly summarize, we proposed the inclusion of perspectives of partners who are actually involved in implementation and the development of our frameworks. And this is related to the inclusion or the recommendation to include partners from LMIC specifically to try to overcome some of those issues that I mentioned on the previous slide. And this is really with the goal to incorporate more contextual nuances and increase our relevance from the start. And then finally, we called for creating more consistent terminology. I feel like we have a lot of frameworks and a lot of them are talking about the same concepts, but they're using different terms or different words. And that really makes it difficult for us to communicate across projects and across contexts. So what's next? I think we're right on time with maybe 2 minutes left. So today we learned that implementation determinants are the conditions that make it harder or easier to implement the thing. And this is all about the context in which the thing would be implemented. And we can leverage this information to inform the development of implementation strategies or the actions that we take to implement the thing. And stay tuned for next week. I believe Dr. Carroll will be explaining this in detail. So I'm going to turn it back over to you to see if there are any course announcements and then take us into our discussion groups.
Great, thank you so much, Amy. So yes, ever-present announcement, please sign up for your small group discussions if you haven't already. I know that we do have coverage for all of today's small groups, but I think there will be ones coming up. So just keep that in mind. And thank you, Miranda, for putting that in the chat. And also, I know we returned at the end of the small group discussions last time to the larger group to wrap up, but we will not be doing that for this session. We want to give you max time with your groups on discussions. If there are larger issues that we want to bring to the full group, the group leaders will do so, or you can obviously always follow up with any of us by email. So with that, I think we will turn it. Oh, there are other resources available in the slides that'll be available for you.